Okay. Okay. So today, what we're going to do is just talk about an introduction to exercise oncology. So, what I'm going to do today is just give a very broad overview of the field and the reason why it's such an important field for us to consider, potentially building a career in. So, I'm going to talk a little bit about cancer and what cancer is, and then get into the side effects from the treatments for cancer. And the reason why I think that's so important is because essentially this whole field was founded because of my research advisor, Dr. Carol Schneider, who she was a exercise physiology professor at the University of Northern Colorado in the early 90s and was going through cervical cancer and used exercise to kind of counteract some of the symptoms and the treatment effects that she was having. And thanks to her work, I'm here today, and this field has grown so much since then. And so it's really important to understand what are these side effects, what causes these side effects, and then how can exercise help, because that's where we're going to kind of come into play. So before we get into any of that, I wanted to introduce myself to you. So my name is Karen Wonders. I live in Dayton, Ohio. I grew up in Pittsburgh. So if there's any Steelers fans on the call, you will get an automatic A plus for joining. But I live in Dayton, Ohio. For the last 19 years, I have worked as a professor at Wright State University. Um, and I'm the program director for the exercise science program and, do a lot of research as part of that role. And kind of before that, when I was getting my PhD, I was at, as I said, the University of Northern Colorado. I always kind of say that I didn't choose cancer, cancer chose me. And so if any of you on this call are considering maybe one day, getting a PhD in exercise science, I probably wouldn't recommend doing it the way that I did it. So basically, what I did was I started as an exercise science undergrad student because I thought maybe someday I would like to go to physical therapy school. And one of the things that I have found with my students through the years is a lot of people come to this field because that is what they want to do. They have this goal of going to PT school, so they pick exercise science because the prereqs fit so nicely. They probably had a background with sports or athletics, when they were in high school, and they just like being around active people and studying that. And that was exactly me. I really enjoyed exercising. And so when I saw I could major in exercise, I thought, well, this is the coolest thing ever. So I signed up. I was an exercise science undergrad with the intent to go to physical therapy school. And then my senior year in college, I basically had a quarter life crisis where it was, I had the grades to get into physical therapy school, but I loved the field of exercise science so much that I just wanted to stay in that field. The only problem was I didn't know what I was going to do with my life working in this field. And so my philosophy was I'm just going to stay in school as long as I possibly can until I figure it out. And that essentially was how I got a PhD. So I stayed and I got my master's degree at the same place I did my undergrad, which was Slippery Rock University. They no longer have a master's degree in exercise science, but I went to school in the 90s, which is essentially the dark ages, and they did have a master's degree back then. And while I was getting my master's degree, one of my professors there suggested to me that I, might enjoy working in higher ed, and he felt like I would be a good fit in academia. So that is really what prompted me to get a PhD. And I always wanted to live in Colorado. So I went to the University of Northern Colorado for an interview, not really preparing the way that I should. You're really supposed to look at the research that the faculty do and try to align yourself with their interests. And I didn't really do any of that. I just kind of showed up and presented my thesis to them, which was a biomechanics study that I had done. And they kind of looked at me and they said, well, that was fine. But if you come to school here, do you know you have to study cancer and exercise? And at this point in my life, I'll just kind of tell you, it was 2003. I was 23 years old and I had never met anyone personally who had cancer. And so I had this idea of what cancer is in my head. And I think it's probably the same one that a lot of us have when we think of cancer. We think of someone who's sick and tired and weak and in bed. And, I remember thinking, how in the world are we going to get someone like that to exercise? I remember like having that conscious thought that I'm going to probably get sued because I was so scared. But I had pretty much committed to getting a doctorate at this point. The University of Northern Colorado was the only school that I had applied to. So, like, all my eggs are in this basket. So, what do you do in an interview situation except for say, well, of course, I've always wanted to study cancer and exercise. And here I am today, 21 years later, 22 years later, actually still studying cancer and exercise. My why really came in 2007 when my grandfather was diagnosed with cancer. And so, kind of giving you the timeline, 2003 to 2006, I was getting my PhD. As a part of my PhD, I had the opportunity to work with patients in person. And I also had an animal lab where we could take rats and we would run them on a treadmill, a human treadmill. We'd run these rats and give them chemotherapy that was supposed to be cardiotoxic. And then we would kind of look at the effect that exercise had in protecting the heart. And, for me, being that I was brand new to this field and didn't really know anything about it, and you guys, this is 2003. So we didn't even have Google back then. So I had to check books out of the library so I could study what cancer was. So, that was how new I was to this field. And I'm doing this research and I'm seeing all this benefits, but I thought everyone else must know this. Before I worked in cancer, I worked in cardiac rehab, and everyone knows that's standard of care. So you have a heart attack, you go to cardiac rehab, they have phases, it's all systematized, and the approach is protocolized, everyone knows what to do. I assumed at the time that cancer was the same way. And so I graduated in 2006, moved to Dayton, Ohio, started teaching at Wright State. And the following year, my grandfather was diagnosed with colon cancer. Now, my grandfather, and you can see his picture here, he was in pretty good shape. He loved to golf. He would walk his German Shepherd 4 miles a day. He belonged to a fitness center called Bally's. Anyone who was alive in the 90s has heard of Bally's, but he would go to the Bally's Monday, Wednesday, Friday, and he called it the spa. You had their whole routine that they would do. So he was very active, but he had a very aggressive tumor. By the time his cancer was diagnosed, you can see this picture of that. That's me laying on the floor with him. That was in June. I was visiting. He was living in Pittsburgh at the time, and he was telling me that his back was hurting him. And, I kind of kick myself for this because automatically my brain goes to cancer all the time. I mean, if my kids have an ear infection, I think it's cancer. And when he told me his back was hurting, it was probably his tumor that he had that was causing him the back pain. But being that he was so active, it never even crossed my mind that he could potentially have cancer. So here I am laying on the floor showing him some stretching exercises he can do to help with his back pain. And 6 weeks later, he was diagnosed with stage 4 colon cancer. At that point of his diagnosis, he had a fist-sized tumor in his colon. It had spread to his liver, his lungs, and he had brain mets. And he actually passed away 5 weeks after his diagnosis. So it was a very aggressive, very, very aggressive illness. And we knew that when he was diagnosed, we knew it was not going to be a good prognosis. But I had seen the benefits that exercise had in numerous patients, in numerous rats. I mean, when you can look at a rat and say, that's a good looking rat, there's something to exercise. You know that there's something to this. And so I insisted that he talk to his doctor and ask him, tell him that you're active already, but you're just going to need some specialized care while you go through treatment. So find out where's the cancer and exercise program. And his doctor kind of looked at him in disbelief and said, oh, no, no, cancer patients need to rest. You should not exercise. And so what I would do is drive to Pittsburgh on the weekends and walk with him. And sometimes we would just walk one lap around the downstairs of his house. That was all he was able to do. But even that little bit of exercise, it made a difference. Even in his final days, it made a difference. I believe it's what helped him to be able to stay in his home until he died. Before he was doing that, he had stopped eating. He, of course, was very depressed by his diagnosis, and this gave him something that he had control over. He didn't choose to get the cancer, but he could choose to exercise. And even if it was just walking around the downstairs of his house, it made an impact in his recovery. And so that kind of stuck with me. I started Maple Tree back in 2011. So my grandfather passed away in seven. It took me about 4 years to kind of put together what it was I wanted to do. The maple trees comes from my grandfather. He had big maple trees in his front yard. But essentially, the reason I started Maple Tree was because I knew there was research. I knew the evidence was there. I mean, I had won awards for research that I had conducted in this field. And yet the medical community was largely unaware at the time of the benefits that exercise can have in the life of someone who's battling cancer. And so probably sounded like a very lofty goal at the time, but I started Maple Tree with the intent of changing the way cancer was cared for. And here we are now 14 years later, and I believe that we have accomplished that. And it's not just due to the work of Maple Tree. I think the field as a whole, we have some amazing leaders in this field. Dr. Catherine Schmitz is our chief scientist. She was the president of ACSM. She has done so much to advocate for this field. We have people that work at ASCO, people at the APTA, people at the American Cancer Society. There's a large consortium of people who are working to bring this issue of exercise for cancer patients to the forefront of major conversations. And ultimately, that's why I'm here today to talk to you all, because I believe we are on the cusp of some major developments in the world of exercise oncology. Last year, the national accreditation programs for breast centers put into standard of care that exercise needed to be a part of standard of care for patients who have breast cancer. So basically, what that means is if you're treated for breast cancer at an NAPBC accredited institution, they have to assess you and refer you to an exercise program and then document that in your electronic medical record. So that was a huge step forward for our field. And that has opened the door for insurance reimbursement to happen. So before we can get insurance reimbursement, you need evidence, which we have. We have lots and lots of evidence. We'll talk about that today. But we also need to have medical necessity. So the fact that this accreditation program is saying our patients that are diagnosed with breast cancer need to have exercise, that shows the medical necessity. And so for the last, I mean, I personally have been working with CMS since 2018, but very seriously since 2023, we've been moving towards getting insurance reimbursement. I believe we will have an approved national coverage determination by the end of this year and insurance coverage for these services by the end of next year, so 2026. What that means for us in the field of exercise oncology is soon, very, very soon, anyone who's diagnosed with cancer could potentially be referred to an exercise oncology program. So whether you're working at Maple Tree or you start your own program or you work at a YMCA, anyone can join an exercise program and it can be covered by insurance. So if you think back to 2018 was when Maple Tree started growing nationally. That was whenever we grew our first satellite site outside of Ohio. At that point in time, there was a research article that was published that said less than 5%, they were estimated it was about 2% of cancer patients exercise during cancer treatment. At the time, we were in a hospital here in Dayton, and I ran the numbers to see how many patients we were working with because I knew it was more than 2%. We were working with 66% of their active patient population. The reason for that is because that hospital made it possible for anyone who wanted exercise, they could come to our program for free, and that hospital paid for it. So if we were able to get 66% of patients to exercise in 2018, before it was standard of care, really before the medical community was talking about it, imagine what we can do when it is standard of care, when it is reimbursed. I kind of ran the numbers. If we have 2 million cancer diagnoses a year, if a third of those patients come to an exercise program, we're going to need about 50,000 trained exercise professionals to meet that demand. Every year, we're going to need that amount. And so you can see very quickly how it is so important that we build a workforce, that we get people who are trained and qualified and really dedicated to making a difference in the lives of people who battle cancer. So again, that's why I'm doing this webinar series. If you have any questions about anything, please feel free to reach out to me afterwards. You can email me. I'm happy to answer any of your questions. So, what is cancer? If you're like me in 2003, I didn't know really what cancer was. I had an idea of like, oh, I know you lose your hair, but like, what is it? So, essentially, what cancer is, if you looked up the definition, is it is a disease that's caused by an uncontrolled division of abnormal cells. So, essentially, what happens is you have a cell in the body, and inside that cell, the DNA of that cell gets damaged. Now, that happens throughout the day. We're exposed to environmental pollutants, there's carcinogens in our food. I mean, for whatever the reason is, we are exposed multiple times throughout our lifetime to something that's going to damage a cell. When that happens in a healthy cell, that cell is programmed to die. So we call that apoptosis. So something in the DNA gets damaged, that cell, as a result, is supposed to die. With cancer, that cell escapes apoptosis, so it does not die. And instead, it starts to replicate and divide basically out of control. And the problem with that, especially as we talk about malignant cells, so malignant cancer, and benign tumors will grow on top of the tissue, kind of like this. They can cause problems. My husband's aunt actually died from benign tumors that were growing in her brain. But most of the time, benign tumors are not going to be the cause of death for somebody. The reason why a malignant tumor is so dangerous is because it will infiltrate that tissue. It'll grow into that tissue, and eventually it will stop the function of that tissue. It'll grow so much that that tissue is not able to function the way that it should. So with my grandfather, he of course had a fist-sized tumor in his colon, so that caused a blockage for him. But also in his liver, I believe that was probably the first place that it spread because it's very close to the colon. And his tumor was growing on both sides of the liver. So it was kind of growing from the sides inward. And what was happening was he had tremendous fatigue. And you think like, well, your liver is the site of, fatty acid metabolism. And so I don't believe that it was metabolizing the way that it should. And as a result, he was just experiencing tremendous fatigue. Same thing whenever it spread to his lungs. He had issues with shortness of breath, and it was difficult for him to breathe. With the brain, of course, he had headaches, he had blurred vision, he had dizziness and balance issues. So though that is what happens with a malignant tumor is it infiltrates the tissue and then it makes it very hard for that tissue to function properly. So, when we're looking at types of cancer, there are hundreds of different types of cancer, hundreds of them, but you can kind of categorize them into these categories. So we have carcinoma, which are cancers that arise in the epithelial cells. So this is the probably the more common cancer types that we see: breast cancer, lung cancer, colorectal cancer, head and neck, pancreatic cancer. Those are all carcinomas. A sarcoma, they're less common, but still cause major havoc because these are cancers that develop in the bone, in the blood vessels, in the muscles. So oftentimes someone who has a sarcoma has an amputation as a result of that. They have to remove their leg, their arm, because of the cancer that has spread. Of course, we have melanoma, skin cancer. We have the liquid cancers, which are the lymphomas and the leukemias. And these are cancers that are going to arise in the immune system and the blood forming tissues. And then finally, the cancers of the central nervous system, so the brain and spinal cord. Those are the major classifications of cancers. If we look at cancer as a whole, just worldwide, cancer causes 1 in every 6 deaths around the world. The one thing to keep in mind is I have seen statistics that say a third of these deaths could be prevented with lifestyle changes, which makes what we're trying to do so important because it's not just helping their treatment tolerance. It's not just improving their quality of life. All of those things are very important, but we can reduce mortality rates with exercise and with healthy lifestyle choices. And so it is a life-saving therapy that we can offer these patients. Of course, cancer is still cancer, and people are still going to die from cancer whether they exercise or not, but it does help these people. A lot of times it can prevent mortality, and it can reduce their risk of other comorbidities as well. So it's very important, I believe. I think every cancer patient should have the opportunity to exercise. By 2024, it's expected that 27.5 million new cancer cases will happen worldwide. So we are definitely seeing an upward trend in cancer diagnoses. At the same time, though, we're seeing less people dying from cancer than ever before. So people are getting diagnosed earlier, which means they're living longer as cancer survivors, which of course is a very good development in the fight against cancer. And this is another place where we come into play, though, because someone who is a long-term cancer survivor is probably going to have long-term side effects from their treatment, and exercise can help them to manage some of those side effects. Just because you've completed cancer treatment doesn't mean you're not going to experience those side effects anymore. So, when we're talking about the signs and symptoms of cancer, it's important to keep in mind that there are hundreds of different types of cancers, and there's no single test that you can take to diagnose someone with cancer. So, some early stage cancers have very significant signs and symptoms that you can be aware of. You can feel a lump, you can have a headache. I mean, there are things that happen that can signal a cancer, but for the most part, the early symptoms of cancer are not very easily identifiable. Sometimes it's a cough that doesn't go away. Sometimes, like my grandfather, it's pain in the back that you just can't really figure out, was it my golf swing? Did I mess it up there? Did I lift too much at the gym? Did I sleep weird? You can kind of explain away a lot of these early signs and symptoms. But as the cancer progresses, generally what starts to happen is the patient will develop symptoms that are specific to the organ that's involved. So, shortness of breath is oftentimes experienced by someone with lung cancer. Jaundice is a very common sign in someone with pancreatic cancer. However, by the time this happens, the pancreatic cancer is more than likely a stage 4 cancer, which makes the mortality rate so high in these types of cancers. The later you're diagnosed with cancer, the later stage you have, the more difficult it is to survive that cancer, which is why early detection is so, so important to patient survival. I feel like here in the States, we have done a very good job with certain types of cancers, explaining why you need to get your mammograms, why you need to get your colonoscopies, why you need your skin checks. We've done very well with that. I have traveled to other countries where screening is not talked about. And I've talked to people about, well, how do people get diagnosed with cancer? Oh, well, my aunt one time went to the hospital because her stomach hurt, and then we found out she had stomach cancer and she died 3 weeks later. And so this is a worldwide issue where we do need to be educating people around the world about symptoms, about screenings and how important they are, and simultaneously trying to develop screenings for all types of cancers, because there's not a screening for pancreatic cancer, there's not a screening for ovarian cancer. And so these are why these cancers are particularly diagnosed in later stages. So there's still much work to be done. So screenings are important. Obviously, if there is a cancer screening, you want to get that screening on time when you're supposed to, and then stay in contact with your medical team if necessary. But screenings are usually our first line of defense at identifying an early stage cancer. If something is suspected, if there's a growth that doesn't look right, or if the mammogram comes back with something, the next step then is to schedule a biopsy. And what the biopsy does is it will take a small piece of that tissue that is a cause of concern, and it will go to the lab, and they are able to, in the lab, identify exactly what that is. Is it cancer? Is it not? If it is cancer, what exact type of cancer? So, for example, if you have to get a biopsy because breast cancer is suspected, not only will it tell you, yes, this is breast cancer, it will tell you the exact kind of breast cancer that you're dealing with. And that is so important because I believe there's more than 100 different types of breast cancer. And so, depending on the different type you may have, that's going to dictate the treatment regimen. So, being able to identify that is very, very important. The next step in that process then is probably to do an MRI or a CAT scan if it's a solid tumor so that you can see the spread of the cancer and see has it gone beyond that tissue of origin. And so that leads into cancer staging. So cancer staging essentially is describing the extent of the tumor. We're going to look at how large it is, how if it has spread, if it's in the lymph nodes, if it has spread to a secondary organ. So commonly, when physicians are staging a cancer, they're going to use this TNM system. T stands for the size of the tumor, so how big is it? N stands for the number of lymph nodes that are involved, and M stands for whether it has metastasized or not. So all of those are going to be indicative of the seriousness of this cancer. They're also going to do a staging of that cancer. And this is a very, very simplistic way to explain what cancer staging is. There's a lot of nuances inside of all of this, but this is something that I learned early on, and it gives me kind of a frame of mind to say, okay, stage two, okay, I know exactly what that means. Yes, there's going to be nuances within that stage two. Was it stage 2A, stage 2B, in situ? Like there's a lot within that, but in general, this is the staging. So stage zero would be carcinoma in situ. Sometimes this is not cancer, this is precancerous. Cells are there. It looks like it could potentially form into cancer. Sometimes someone that has a stage zero cancer will opt for like a surgery or something to remove those cells to reduce their risk of it actually developing into cancer. Stage one cancer is localized. So it's a tumor that is in that tissue of origin and has not spread yet beyond that tissue of origin. And generally, these tumors are going to be less than 2 centimeters. So, about the size of my thumb. They're going to be pretty small. This, of course, is an early stage tumor. Survival rates are going to be much, much higher if you can catch it in stage one. Stage two generally is going to be a tumor that is between 2 centimeters and 5 centimeters, so a little bit bigger. And it potentially may have spread to some lymph nodes. You might have some lymph node involvement there. Stage three is going to be a little bit of a larger tumor and more lymph node involvement, potentially another metastasis, or it might have spread to another tissue. If that is the case and it's a stage three, usually that's going to be a tissue that's close by. So with my grandfather, with the colon cancer, if it had just spread to his liver, well, the liver's right next to the colon, that could have potentially been a stage three. He would have had a much better prognosis if it were caught when he was stage three. Stage four is going to be a distant metastasis. So my grandfather having the tumor in the secondary tumors in his liver and his lungs and then his brain, think how far away your brain is from your colon. The fact that it reached all the way up to his brain means that throughout his lymphatic system, those cancer cells were traveling throughout his body. And by the time you get to that point, the cancer is more than likely so widespread that survival is going to become much, much more difficult. And, the treatments are going to be more severe. It's just a much harder illness to treat. So, speaking of treatment, generally treatment is going to depend on the person's physical and medical conditions. So, they really do take into consideration the patient's medical history, any comorbidities that exist. I mean, I have sat in tumor boards before where they talk about support systems and do they have transportation to make it to treatment? And, all of those go into play whenever they're talking about creating this treatment plan for a patient. Generally, it's going to include a combination of things. So, almost always you're going to have surgery. And then you're probably going to have a combination of some of these other things. And we're going to talk about all of these. But most often, the order of these treatments is going to be determined by the size of the tumor. If it's a small tumor and you don't have a lot of lymph node involvement, it hasn't really spread, oftentimes surgery will be the first line of defense. Maybe you'll do radiation and chemotherapy afterwards just to make sure you've killed off all of those cancer cells. On the other hand, we have had patients, particularly with breast cancer, we see this a lot, where they have a very large tumor. And so, as a first line of defense, they'll get chemotherapy first. And the goal with the chemotherapy is to shrink the size of the tumor, and then they go in for surgery. So, the order of treatment is always going to be dependent upon the type of the tumor that is present and the size of that tumor that is present. So you might hear these terms kind of thrown around. Doctors are going to use these terms a lot. So you hear adjuvant therapy and neoadjuvant therapy. So adjuvant therapy is going to be a therapy that is given after surgery. So typically that's the traditional, if it's an early stage cancer, they'll have surgery and then the adjuvant therapy might be radiation, it might be chemotherapy, it might be hormone therapy. And that adjuvant therapy is done in order to reduce the risk of recurrence. Now, on the other hand, what I talked about earlier, if you have a big tumor that they want to give chemotherapy to first to try to reduce the size of that tumor before they do surgery, that's when we call it neoadjuvant therapy. So, neoadjuvant therapy is going to be the chemotherapy or the biological therapy that's given before surgery. Adjuvant therapy is surgeries first, and then we do the other therapies. It took me a long time to know the difference between those two terms, so don't feel bad if it's confusing for you. In terms of treatments, there's 5 broad treatment categories, and I want to talk just briefly about all of these. But we've got surgery, radiation therapy, chemotherapy, biotherapy, and targeted therapies. Now, keep in mind, particularly as it relates to chemotherapy, there's so many different types of chemotherapy drugs. So I'm going to talk about kind of in general the way chemotherapy works and the way these particular medicines work. But keep in mind, it's probably a very simplistic view of the overall cancer treatment spectrum. I will say, though, as exercise physiologist, I think it's important to understand how these therapies work and kind of what is the intent behind these surgeries, but don't feel like you need to have an oncologist level of understanding of these things. So let's talk about surgery. Surgery is the oldest treatment for cancer. There are drawings that date back to like 300 BC of, people that have a growth and they're, using surgery to excise that growth. So the longest and probably the most common, I think almost everyone who has cancer is going to get some kind of surgery. There's different types of surgery for different purposes, but in general, we're going to break it down into 2. The first is curative, and that is, hey, we can excise this entire tumor. So if it's a small localized tumor, say in the breast, you can have surgery to remove that. And you might not even need an adjuvant therapy following that surgery. Sometimes it's still given as a precaution, but, this is the best case scenario. If you can excise that whole tumor, get all of that all of that growth out, and sew the person back up and they're ready to go. That's the best of all worlds. Now, the complete opposite of that is when we use surgery for palliative care. So sometimes you have a patient who does not have cancer that is curative, and they're probably going to die from this cancer. I have a friend whose father had stage 4 lymphoma, and he battled it for many, many years, tried many different experimental therapies. He tried CAR T cell therapies, and he was on clinical trial after clinical trial, and nothing was really working. And they knew that treatment was not going to be successful for him. And so, he eventually stopped treatment, but he had a growth that was kind of growing right here in his chest and was pushing on his lungs, which made it difficult for him to breathe. And so, even though they knew, like, if we take this tumor out, it's not going to cure you of your cancer, but it'll still make it more comfortable for you so that you can breathe easier. as are still, this cancer is still spreading in your body. So that would be an example of palliative therapy, just done to really make someone more comfortable. It's probably not going to improve their means of survival. Radiation therapy works by stopping the growth of the DNA in the cells. So if you remember, I talked about the way that cancer cells grow is because the DNA gets damaged and that cell continues to grow and evade apoptosis. So what the radiation therapy can do is it can target the DNA of that cell and it can stop it from replicating. So it's very effective. It's great for localized tumors that have not metastasized because you can really pinpoint that specific tumor and help to kill it. And the side effects from that are really not that bad. I mean, fatigue is a major side effect. Skin burns are major, but otherwise, oftentimes when radiation ends, that patient is able to resume basically a normal life. When it comes to chemotherapy, chemotherapy is given usually intravenously or orally. And the way that chemotherapy works is it interferes with cell replication. So if you've had cell biology and you've studied the different phases of the cell cycle, the way chemotherapy works is it's programmed to attack cells that are in a specific stage of the cell cycle. So we'll just say, for example, the gap 1 phase. Someone's treated with chemotherapy, it goes into the body, and every single cell in the body that is in the gap 1 phase, it will attack. It will interfere with the DNA replication and it'll destroy that cell. The problem with that is it cannot tell the difference between a healthy cell and a non-healthy cell. So you have healthy cells that rapidly divide, like your hair, like your skin, and chemotherapy is going to target those cells and it's going to kill those cells. So that's why you have such severe side effects when it comes to chemotherapy. And that's also why chemotherapy is given in cycles. Usually it's every 3 weeks. Usually it's given in combination with multiple different kinds of chemotherapy drugs, and it's all designed to get to those cells that are replicating and stop them from replicating. So it's effective at fighting cancer, but the side effects are going to be tremendous. It can greatly impact an individual's quality of life. Targeted therapies, we're starting to see more of these come out in medicine. Essentially, these are called precision medicine. So they consider the variability of individual responses to cancer treatment. And they use things like genetic information about a tumor to formulate an individualized approach. So the example here is the HER2 receptor. There is a certain type of breast cancer that expresses the HER2 receptor. And essentially, what Herceptin does is it's a drug and it'll bind to that receptor and it'll lead to the arrest of that cell. So that cell will die. So instead of, what it's supposed to bind to it to make that cell grow, Herceptin kind of comes in its place and binds to that receptor. Before Herceptin was invented or discovered or whatever the correct term is, that type of breast cancer that was HER2 positive was very, very deadly. Most patients who got that breast cancer, maybe they survived the first round, but then it came back, and usually it was deadly at that point. Since Herceptin has been developed, I mean, there's a reason why they call it the wonder drug. It has reduced breast cancer mortality significantly. And not only that, but you also see um, recurrence rates have significantly gone down as well, almost to zero. So it is a very, very effective treatment. Now, I did my dissertation on Herceptin, and one of the things with Herceptin is if you combine it with chemotherapies, particularly adriamycin chemotherapies, you see a lot of cardiotoxicity develop again, which is where exercise comes into play. Hormone therapies can work with certain types of cancers that use hormones to grow. So when we think of breast cancer, certain types of breast cancer, certain types of prostate cancer, we can use hormone therapy in the treatment of those. Now, as we've talked about, there are a lot of side effects that are associated with cancer treatment. You can see psychological side effects that cause harm to the tissue and the body functions. These toxicities are going to be dependent upon the type of therapy that you have and oftentimes the cumulative dose. So maybe the first time you get chemotherapy, you don't see a lot of cardiotoxicity develop, But by the time they're on their sixth round and you have that cumulative dose that is so high, cardiotoxicity might have developed to a point where they have to take the patient off of that medicine and put them on something else, because what's the point in fighting your cancer if you're going to die from heart disease? So it becomes a dose limiting effect. In general, these acute effects and that are, the things that are going to have a great ability on an impact on someone's ability to exercise. I think these are all things that we're familiar with whenever we think of cancer. We think of fatigue, nausea, vomiting, pain, peripheral neuropathy, anxiety, depression, muscle weakness. All of these things are very commonly experienced by cancer patients. I mean, upwards of 98% of cancer patients are going to experience side effects like this. There are also long-term and late effects of treatment. And so, as I said, just because treatment ends doesn't mean sometimes that these side effects don't go away. Oftentimes, patients are going to experience these side effects here, and they may persist sometimes for the rest of their life. So, peripheral neuropathy oftentimes is experienced by patients, fatigue, depression, anxiety, fear of recurrence. All of these are going to be long-term and late effects of cancer treatment. So, before we transition to the next slide, I just kind of wanted to share a little bit about one of our patients that we have. So this is Sandy here. Sandy came to us in a wheelchair because she was receiving pelvic floor radiation, to her pelvic area, and oftentimes that's associated with a lot of pain, and it makes it very, very difficult for patients to walk. Now, Sandy said she was more afraid to come to Mapletree than she was to do her chemotherapy, which was a very like for me that I was when she said that, it just kind of changed the way I approach patients, because I always thought they looked at it like this is going to help you, this is going to be a good thing. I never really considered there is this emotional component. If you take someone who's never exercised before, you take someone who's in a wheelchair and you tell them to exercise, that can be such a daunting thing for them. And so to kind of consider that when you're working with patients. By the end of her 12-week phase with us, she was able to walk without the use of her wheelchair anymore. So she made significant progress being in our program, and really accredits that to the exercise program that she had. And so we really believe that exercise oncology can lead to better outcomes when it comes to fighting cancer. And it's not just, something that we believe. There is so much research to support this. So when we use this term exercise oncology, when I first started in this field in 2003, we did not have this term exercise oncology. We kind of called it, well, it's cancer rehab, but it's not rehab because we're not physical therapists. So what do we call it? Like, we didn't really have a term for it. So Katie Schmitz coined this term in 2017. We've been using it ever since. Exercise oncology is the use of physical fitness to enhance the lives of people with cancer and cancer survivors. If you look at the literature, the very first published study in the field of exercise oncology was in 1986. And basically what this study was it was a forced swimming study. So they had rats that they forced to swim, that had tumors. And the thought of the researchers was they believed that if these rats with tumors were forced to exercise, the exercise would increase blood flow in the body, which would cause cancer cells to spread. And they believed that these rats would die sooner than rats who remain sedentary, which goes right in line with what physicians believed for so long. Oh, if you have cancer, you need to rest because you don't want to overtax your body. Well, what these researchers found was the exact opposite. The rats that exercised lived longer than the rats that were sedentary. And so, you can see here, since then, I mean, these are randomized control trials. Randomized control trials are the gold standard in research. But if you just went on PubMed and did a search on cancer and exercise, you would find more than 30,000 published articles on this topic. And when we're looking at just randomized control trials that are published, we now have more than 3,000 of them. So the evidence is there. The evidence is so compelling that is why we've been able to get the attention of CMS. In 2019, ACSM published three roundtable papers that produced guidelines for the field of exercise oncology and also did a review of all of the literature that documented the benefits to exercise during cancer treatment. So the literature for these specific side effects was strong enough that they were able to say, in this consensus from this roundtable, these are the benefits of exercise during cancer treatment. We also know that there is evidence to show exercise helps with other things as well that are not listed here. For example, when I did my PhD, I studied cardiotoxicity, and I saw time and time and time again that exercise is beneficial against cardiotoxicity. The reason it's not listed here is because there might just not be enough evidence, enough published research in a human model, not a rat model, that shows the benefit. So I believe every body system gets better as a result of exercise. These specific ones, are definitely tied to it. This has led to several national and international organizations to endorse exercise oncology. So, what that means is they're telling their constituents that exercise should be a part of cancer treatment. So, ASCO, the American Society of Clinical Oncology, is the largest clinical oncology group in the world. In May of 22, they published a guideline paper that said any patient who is treated with curative intent needs to be referred to an exercise program. That was the strongest statement by any American oncology group to date. And that, again, is what has opened the door for these conversations that we're having with CMS. In addition to that, our application that we're giving to CMS for insurance reimbursement has ASCO is the primary supporter of that. So it's on an ASCO letterhead. This is a huge organization that holds a lot of power and a lot of weight and is something that CMS will see and take very seriously. So it's awesome that we have their such strong support in this. A couple other things I wanted to point out. If you look over here, the National Accreditation Program for Breast Centers, they're the ones that have put exercise into standard of care for breast cancer treatments. We are currently working with the Commission on Cancer to do the same thing for all tumor types. And then here, almost at the bottom, the Clinical Oncology Society of Australia. Back in 2018, they're the ASCO equivalent in Australia. It's called COSA. They made exercise standard of care for all tumor types and even have reimbursement in place for that. So Australia, in my opinion, is leading the way, but I feel that very soon we're going to catch up. So let's look at these side effects and look and see how does exercise help mitigate some of these side effects. So I want to just take a closer look at some specific ones. For example, we oftentimes see muscle damage, muscle weakness that happens. And a lot of times this is because of the treatments that patients get. And this is severe enough to cause muscle weakness and to cause major fatigue. However, we believe and we know exercise is medicine. So when someone exercises, what they see is an increase in the integrity of muscle tissue. We see protein synthesis. We see hormones that are stimulated that lead to muscle cell growth and development. And we also see an improved metabolism. So scientifically, this is how exercise can help counterbalance that muscle weakness that we see. We also see cardiovascular treatment. Just real quick, I want to point out this woman here that I'm working with. Her name was Patricia. She came to us when she was 83 years old. She had never exercised a day in her life, and she was with us for 5 years. So I love to share her story because I'm like, anyone of any age, it's never too late to start an exercise program. We all lovingly called her grandmother. Um, so side effects, cardiovascular disease. Oftentimes we see cardiovascular disease happen as a result of the cancer treatments. And what we see is a decrease in left ventricular function, reduced ejection fraction, diminished contractility. Oftentimes it's going to lead to a reduction in stroke volume and cardiac output. But as we know, exercise can strengthen the heart. It can improve the cardiovascular efficiency. So you see an increase in cardiac output and stroke volume, a decrease in resting heart rate, and lowering of the exercise heart rate. So the heart gets stronger. On average, the patients that we have go through Mapletree, and gosh, I think since our inception, we've had more than 20,000 patients now go through our program. We see an average of about a 16% improvement in cardiovascular endurance. while someone is in chemotherapy. So while they're getting these cardiotoxic drugs, if they exercise, their heart can actually be stronger at the end of the exercise program than what it was before they started chemotherapy, which is amazing. We also see psychological health improvement. So fatigue happens to about 97% of patients. Oftentimes, this fatigue is expressed as a whole body overwhelming fatigue. My grandfather, when he was experiencing this fatigue, he told me, I'll never forget the first time I saw him. He was sitting in his bed that was brought into the downstairs of his house, and my grandmother was feeding him scrambled eggs. And he looked at me and he said, "You have no idea how exhausting it is for me just to eat these eggs." So that fatigue is beyond just, "Oh, I'm tired, I didn't sleep well." I mean, it is so overwhelming that it makes it difficult for someone, even if someone feeds you scrambled eggs, that's exhausting for them to eat. And so sometimes you think, well, if the fatigue is that much, how in the world are they going to exercise? And so what I always tell people, and this is exactly what I told my grandfather, was let's just see what you can do. Can we get you up out of bed? Can we walk one lap around the downstairs of your house? That's it. Then we'll go back to bed. That's all you have to do. Oftentimes, just that little bit of movement, even if it like someone looking from the outside in would think like, why are you even bothering with that? That little bit of movement can really help. For my grandfather, it boosted his mood. He would get excited whenever it was time to do his exercise, even if it was just walking. It allowed him to eat again. So it had a real profound effect on him. So meet the patient where they are and help them, to do what it is that they can, but keeping in mind that something's always going to be better than nothing. So we do see that. We see that exercise helps decrease fatigue. It also improves quality of life. It helps to decrease worry and anxiety because it's giving these patients something tangible that they can do in their fight against cancer. I did want to share these with you just because I think it's so amazing, some of these statistics that we have had. So this is again on more than 20,000 people who have gone through our program. We see a nearly 60% improvement in their quality of life, 15% improvement in cardiovascular endurance, 18% improvement in muscular endurance. Patients improve their range of motion, they feel more positive, they feel supported. We also see a decrease in healthcare utilization. This is data that I oftentimes present when I'm talking to hospitals or when I'm talking to insurance companies, because this is data that's going to save them money. But it also saves the patient money as well. If you're not staying in the hospital as long, if you're not going to the ER as much, all of that is going to help save money. And we see significant cost savings in patients who exercise compared to patients who don't. We published a randomized controlled trial about 2 years ago that, and this is Dayton dollars, so keep that in mind. But in 12 weeks of exercise for these patients, we saw a cost savings of about $2,100 per patient. So you subtract out the cost of the exercise program, we're saving the hospital $1,500 on every patient that goes through our 12-week program. That's significant when you think of 2 million people that are diagnosed with cancer every year. I did want to share this quick story with you. This is Bill. Bill was diagnosed with cancer, and it was a lung cancer, and he had a lot of fatigue and shortness of breath as he was walking and doing a lot of physical activity. And his daughter was getting married, and he was very concerned about whether or not he was going to have the stamina to be able to walk her down the aisle. And so that was something that he worked with his patient with his trainer on, and they were able to get him to the point where he was able to walk his daughter down the aisle on her wedding day and having such a special moment with her. So when we think of exercise, oftentimes as exercise physiologists, we're going to think in terms of cardiovascular endurance and muscular strength. But when we realize, oh, it can help this person walk their daughter down the aisle. It can help this person, reach a glass out of the cupboard and bring it down. This person can open a jar now and cook for themselves. There are very tangible impacts that this can have on someone's life that is going to greatly improve their quality of life. So very quickly, I just kind of want to go through some of the components of an exercise program. We we promote individualized exercise training. So someone is referred to our program, we're going to do a pre-screening on them. We're going to look at their cancer history, their medical history. We're going to do a fitness assessment so we can identify strengths and weaknesses. And then based on that, we create an exercise prescription that's customized to that patient. And then depending on where they are in their cancer treatment, this is how we set their exercise intensity. So someone who's in prehab, who has not yet started treatment, that person, we can get some baseline testing in. We can talk about, how you're going to stay active as you go through treatment. With phase one, we want to protect their immune system. So we're going to exercise them at a little bit of a lower exercise intensity. Phase two, our goal here, this is still considered active treatment, but we want to get their self-efficacy to the point where when they complete their treatment, when they enter their long-term survivorship, they have that self-efficacy so that they can continue exercising in a community-based setting. And that would reduce their risk of recurrence, their all-cause mortality goes down. So that's ultimately what we're trying to do there. Now, one of the topics we're going to talk about in this webinar series is this continuum of interdisciplinary care. So we are one piece of a much larger puzzle. And there might be a lot of students in here that are watching this that are interested in physical therapy. And you might be thinking, well, I don't know if this relates to me. Well, it definitely does, because there is such a need right now for physical therapists who are trained in oncology. It is a glaring, glaring disparity right now. They don't have enough to go around at all. And so this is something where if you join this field with the intent of going to physical therapy, this could be a differentiator for you as you're looking to apply to PT schools. If you still just want to stay in exercise science and work in the field, we work very well with physical therapists. We have a triage system that we use to assess whether the patients need to go to PT or not. And then we keep that door of communication open so that we can sometimes work in parallel and they'll focus on the impairment and we kind of do a whole body exercise program. Or, the patient goes to PT and then they hand them off to us, or we're with the patient and then we start seeing signs of lymphedema, we hand it to them. It's a team that we come together to really complement each other. And that way everyone is kind of staying in their lane, using the highest and best use of their degree. Some common myths that we see with exercise, and these are just things that might come up whenever you start talking to people about this, is, are they too sick to exercise? That's what I thought when I first started working in this field. Is it too risky? Could they get hurt? Is it too much for them? Shouldn't they just rest? So those are things that you definitely will hear a lot about. Now, in reality, we know there are clear exercise protocols and guidelines that exist. And oftentimes, patients are ready and eager to participate in an exercise program. I look at this as a changeable moment in their life where they're going to be oftentimes more open to embracing a lifestyle change. And then, what I think is so rewarding about this work is that you can see tangible improvements in the patient's life. They can walk their daughter down the aisle. They don't have to use a wheelchair anymore. There are tangible things that happen. So as we're looking at the workforce here, what kind of workforce do we need when it comes to exercise oncology? You'll see that there is this continuum of care in place where at the very top, that's going to be the onco-trained physical therapist. Sometimes we see physical medicine doctors up here. Oftentimes, they're going to be the ones to assess and triage the patients, but not always. We have many examples where we're the ones that do that because they're so backlogged with patients, there's a waiting list. That middle therapy here, or the middle section here, that's going to be clinical exercise oncology instructors. So people who are working inside of the hospital. With Mapletree, we have 86 clinical partnerships across the country where we're offering programs either on site or virtually to their patients, and we see them during that active treatment. So those people, if you want to work in that field, generally are going to need a 4-year degree in exercise science or a related field and a specialty certification. So Mapletree offers the exercise oncology instructor certification. ACSM has a certificate that they offer, cancer exercise trainer. There are options out there. And then that final layer is for people who have completed active treatment who are going to be working in the community. In this, one of the things Mapletree does is we partner with Livestrong, and we have revamped their Livestrong certification. It's now called Cancer Fit. And it is appropriate for someone who may not have a degree in exercise science, but they might work as a fitness professional and have another personal training certification. They can take that Cancer Fit certification, and that would qualify them to work with a patient who has completed active treatment. So now they're in their survivorship phase. So the workforce consists of all of those layers. It's not just going to be the clinical exercise physiologist. We want to get people moving and active as long as possible. So your role as an exercise oncology professional is to perform the patient assessments, to create those individualized programs, to complete the one-on-one sessions, monitor progress, and then document and report as things happen. Of course, we want to be there to prepare you and to help you every step of the way. And we have prepared over 1,000 people now through our programs that we have had that have worked at Mapletree or worked on their own. And so this is something that we're very passionate about. So don't feel like if you see this list, you feel overwhelmed. We want to help you every step of the way to do that. But some skills and qualities that I think are very important when it comes to working in this field. Obviously, you want to have a strong exercise science foundation. You do want to have a national certification, such as our exercise oncology certification. You want to have excellent communication skills and empathy and compassion. I mean, think about it. When you're working with a cancer patient, they're in the hardest, most difficult journey probably that they have ever walked through. And so you want to be sensitive to that and provide that education, be problem solving, use teamwork, trying to make a difference, but also show empathy and compassion to what they are experiencing and understanding that you're going to have a significant impact in their life as they're battling cancer. And as I've said, I really believe that the future is so bright with the field of exercise oncology. Mapletree's been around for 14 years, and I feel like we are just getting started. I mean, I think soon you're going to see exercise oncology in every hospital in the country. And so there's never been a better time. If you are a student that is watching this and you're just trying to figure out what to do, there has never been a better time to be in the field of exercise science, whether you go into exercise oncology or clinical exercise or even, something else, working with a sports team or wellness. People are talking about it. You're hearing about it on the news almost every day. This is the time to be in this field. And I really believe that we can make such a meaningful difference in the lives of millions of people if we come together and do this. So we're seeing this growing recognition. We're in healthcare. We're seeing the movement towards insurance reimbursement. We're seeing more and more programs pop up. I believe soon it will be standard of care for all tumor types, and then international growth and recognition. Mapletree alone, we're working with 25 countries around the world to establish programs and to train and certify a workforce in their individual countries. And my goal is someday to be in 80. So like I said, we're just getting started. So that is the end of my presentation. I did want to share this with you. If you want more information, I would welcome you to join us on a social media channel that we started recently called Mapletree Education. The idea behind this is to just become a resource for you, whether you work in the field of exercise oncology or whether you're just curious about what does it look like. Maybe clinical exercise phys is your thing and you just want to learn more. Go ahead and follow us there. We break down research studies. We give tips and tricks and a whole bunch of other things. There's like day in the life so you could see what it's like to work in the field, but please feel free to join us over there. And thank you for your attention. I apologize. I try to keep these under an hour, so I apologize for going a little bit late. I'm going to stop recording. And that is all that I had. So next steps here, we will send out a recording of this tomorrow to everyone who is registered. Please feel free to share this with whomever you like, whoever you think would be interested in this. And we're going to be doing these webinars. There's going to be a different topic every other week from now until April. We'll take a little break in the summertime and then we'll pick it back up again in the fall. And really, my hope is I just kind of want to break down some of the barriers here in this field of exercise oncology. So if you have an idea for a topic, please feel free to share that with me because I'd love to hear it. I'm anxious to dive into many different subjects. So thanks again. Feel free to sign off, but I hope you all have a wonderful night, and hopefully I'll see you again in 2 weeks. Bye. Thank you.